This is Emily Peters recording for Unit 7. The PowerPoint on, actually this is just going to be respiratory. Alright, so our first topic is rheumatic fever. Rheumatic fever is an inflammatory disease that affects the heart, the joints, and the central nervous system. And it also can affect the subcutaneous tissue. One of the biggest issues with rheumatic fever is it can affect your cardiac valve and damage it. Specifically, the mitral valve can scar and therefore it won't work correctly. The etiology is it's a link with upper respiratory infections that are caused by group A hemolytic strep. Those that have group A strep and it's basically not treated effectively will develop this rheumatic fever within 2 to 3 weeks. Once again, we can prevent rheumatic fever, and in the United States we typically do by treating our strep infections adequately. How do we decide if somebody has rheumatic fever? Is we use the Jones criteria, which I have it kind of broken down on the next slide, but you have to have the presence of 2 major criteria or the presence of 1 major and 2 minor criteria. So here is that Jones criteria broken down. The major criteria is carditis, polyarthritis, erythromargitum, subcutaneous nodules, and chorea. And we'll define these closer in class. And then the minor criteria would be arthralgia, fever. You could also have an elevated antitrypsin O titer, an elevated ESR, a C-reactive protein, and they may even do an ECG and see what's going on with the heart. So how do we take care of somebody with rheumatic fever? The main thing we'll do is penicillins. We also will do NSAIDs and corticosteroids for that control of the inflammatory process and decrease fevers and discomfort due to that inflammatory process. We also recommend some bed rest. With the medications or the antibiotics, we'll do a lot of prophylactic treatment as well against the reoccurrence of rheumatic fever. So we don't want these people to have reoccurrent episodes. So we have a couple different choices of either doing penicillin G, IM injections given monthly, or we can do 2 oral doses of penicillin or 1 dose of sulfa every day. We'll talk more about the duration and the issues along those lines. And then what we as nurses need to do related to treatment of rheumatic fever in class. The next thing is hemophilia. Hemophilia is a type of a bleeding disorder due to a deficiency in clotting factors, which, as we know, clotting factors are necessary for coagulation of blood. No matter what clotting factor is deficient, because you have different types of hemophilia that have different clotting factors that are deficient, you're going to have the same kind of symptoms with each type of hemophilia. We had the classic hemophilia, which we're going to basically focus on in class. And then we have hemophilia B, which is called Christmas factor. I'm not sure why it's named Christmas. Okay. Another name for Christmas is von Willebrand disease as well. Oh, no, wait. Von Willebrand disease is another type of, like a clotting issue. Excuse me. Von Willebrand disease is a disorder that affects girls. Hemophilia A, or the classic, is a deficiency in factor 8. It typically affects boys, and it is 85% of the cases of hemophilia. Hemophilia B, also, like I said earlier, was the Christmas. It is a deficiency in factor 9. So hemophilia A, which is factor 8 deficiency, or the anti-hemophilia factor, AHF, is what you may see it listed as. You have a decrease in this AHF in the patient's blood. So therefore it results in that increased severity of the disease process. Factor 8, or AHF, is produced by the liver and is necessary for the formation of thromboblastin in the phase 1 of blood coagulation. Now, they can have bleeding that can occur anywhere, but there are a couple areas where it's more common, such as joint cavities and the muscles. So why don't you think about some signs and symptoms that we would be able to tell if there's swelling or the bleeding going on in that area. And then we'll discuss some other big issues that can occur. Now, with hemophilia, these patients can end up with crippling deformities, especially if they keep having repeated episodes multiple times. And this could be in a year or over multiple years. So these kids, if not treated well and given the right types of treatments and assistance, can become crippled. Diagnosis is we're going to be looking for that prolonged bleeding time. So what kind of lab do you think we would be looking at? We'll answer that in class. So what do? Well, the big thing is we need to replace that clotting factor. What we'll do is we'll do pooled plasma, or we may use a genetically engineered recumbent and give these to the patients. We also need to do joint exercises to strengthen that joint. This will also help decrease that number of spontaneous bleedings by strengthening how they use that joint. We're also going to teach the family and that child on how to administer that AHF when they have acute bleeding and those prophylactic times. One form of medication we may use is desmopressin because that can help stop the bleeding. These patients can have really good prognosis because of all the research we have. Another thing that can be an issue for families, and hopefully this is becoming less and less issue, but in the past, just like with blood products, HIV and AIDS was a huge risk factor, especially before 1985. So that's something to kind of keep in mind when we're educating our families. Since 1985, the risk for HIV and AIDS has drastically decreased. In fact, there is no risk because we are doing all the screening processes. But people still worry about that, just like people do with blood products. Because these donated plasma and things are also a blood type of product. So nursing care and interventions. Well, one of the newest things is we're avoiding NSAIDs. So example of ibuprofen for those with hemophilia. So they should never take any. So no aspirin, Advil, ibuprofen, Midol, Motrin, Bufferin, Bayer, Alka-Seltzer, Excedrin, Pepto-Bismol, because all of those things thin the blood. And if you have thin blood, that increases bleeding time. So pain relief, the only approved thing at this point that I'm aware of is Tylenol for these patients. So we have a patient that is having a bleeding episode. What do I do? Well, hopefully, first off, we can prevent bleeding by educating the parents with how to make a safe environment for infants and toddlers. School age, what should they be doing at school? Protective gear. They really technically shouldn't be doing contact sports. We also need to teach our families that their school nurse needs to be very aware of this issue with the patient so that she can recognize and control the bleeding, but also inform the teachers or the recess supervisors or whomever is going to be with these patients frequently. The sooner we can recognize and control the bleeding, the more effective treatment will be. We need to listen to those kids as well because they know when the bleeding is occurring. And so we need to get that factor replacement, the desmopressin or whatever the child has been prescribed, done quickly. Another thing we can do during that bleeding episode is to do RICE. Rest, ice, compression, and elevate. Also with that is when we're elevating, we need to do some immobilization of the joint. And then afterwards, we need to do some range of motion. Now this is after that acute episode to keep strengthening that joint. Okay. Okay, so this one I think we'll discuss mostly in class, but kind of make a list for yourself on what kind of things am I going to assess for. So think back to health assessment. And what kind of things increases our risk for having a respiratory tract infection. So things that put me at risk and things that I can do to help these patients. Okay. So when we're taking care of a kid with a respiratory tract infection, what am I going to do? Well, first of all, don't we want to ease their efforts? So what kind of things can we do to help with that? Promote rest, promote comfort, prevent the spread of infection, and reduce their temperature. We also need to make sure we're keeping these children with great hydration and nutrition. So what are some things we could do as an intervention to ease the respiratory effort? Cool or warm mist in humidifiers may be a possibility. This soothes inflamed membranes. Bed rest, especially if there's a fever. Comfort. Can we put saline nose drops in? Should we use a nasal aspirator? Are throat gargles okay? Maybe a throat lozenge to let them suck on. Can we do cold or heat packs if there's inflammation of the lymph nodes to help with that swelling and discomfort? We all should know this, but how do we prevent the spread of the infection? The hand washing, not sharing cups, covering our cough. How do we decrease that fever? Tylenol, children's ibuprofen, cool liquids. We may even be doing like a tepid or a lukewarm bath. Promote hydration and nutrition. So we sometimes will let those kids determine their own food need. So we are going to actually push a little bit more of the fluids. We're not going to do those high-cal drinks like sugar, juices, pop. So yeah, like pops and things like that. Especially if there's diarrhea, because it's not going to help, right? Maybe we need to recommend some Pedialyte. If you've never dealt with a sick child before, you're going to know that they can be difficult. They can be irritable. So we need to support the child and also support the family and help them realize things they can do and know that they are doing everything possible to take care of their child. Okay? The next slide is just talking about antitussives and expectorants. So antitussins, expectorants, and mucolytics are good, but we also got to remember that under the age of like 5 or 6, they're not really recommending some of these over-the-counter medications. So I wouldn't use them unless the doctor specifically says to use them, like our Robitussin, things like that. They are starting to make some of these that are better for pediatrics. However, there are some things that we have to be aware of. Okay, we may need to teach our families on how to use them correctly if prescribed. What to watch out for. So common upper respiratory infections are going to be like your common cold, which are typically your viruses, your pharyngitis or your sore throat, or your strep throat. Okay. Most upper respiratory infections are viral. Most kids with these things have discomfort from a stuffy nose. So what can we do to help them? Fever, elevate the head of the, treat the fever, elevate their head of the bed, suction, increase fluids, maybe used humidifier or mist. Give them antipyretics. Make sure they rest until they're free of a fever for 1 day. Technically, if a kid has a fever, they shouldn't, in the past 24 hours, they shouldn't go to school. We're not supposed to be using decongestants. So pharyngitis, also known as a sore throat. What are we going to do? We need to do throat cultures. We may do cough suppressants. No infection after 24 hours post antibiotics. So they can go to school once they've been on antibiotics for 24 hours, especially with strep throat. We need to watch for those signs and symptoms. Typically, pharyngitis is viral, so then we're just going to treat the symptoms, but we need to keep a close eye on it to make sure it isn't bacterial, because the bacterial is the group A beta hemolytic strep that can lead to that rheumatic fever. So we would need to start that penicillin soon after. Also, besides rheumatic fever, you also could have glomerular nephritis, so we need to keep a close eye. If it is definitely strep throat, they need to have that 7 to 10 day course of antibiotics. And like I said earlier, penicillins. Also, remember, once you've been on those antibiotics for 24 hours, we should get rid of that toothbrush. So change that toothbrush after 24 hours on the antibiotics. We technically should do this once we're better healthy from colds. Okay. We can also have those children do warm saline gargles. And then once they've been on their antibiotics for 24 hours, they can go back to school. Throat cultures is something we're also going to need to do for these kids. This slide just tells you how to do a throat culture. Also be aware when you're doing some of these throat cultures, nasal swabs, things like that, that you're using the correct tubes, but also you're getting them to the lab in the correct way. Certain ones need to be sent on ice or just be kept cold. Because these can be very uncomfortable to do, we just want to make sure we're doing them correctly and transporting them to the labs correctly, because we don't want to put those kids through these tests again, even though they're pretty harmless. But they're uncomfortable. Some other things that we need to worry about with upper respiratory infections is tonsillitis. This is very common with pharyngitis as well. Tonsils, what do? Let's discuss this in class. I hope you guys are all aware of the uses of our tonsils. If a child has chronic tonsillitis, we will eventually do a TNA, or a tonsil and adenoid removal. It varies by doctor to doctor. Some say if you've had 5 or more infections in a year, despite giving antibiotics and doing what you're supposed to, then we're going to remove them. Some will say if you have multiple years of them, just kind of listen to your doctor. What do? Well, after the TNAs, these kids are going to be still groggy from their anesthesia. When they are still under the influence of anesthesia and have not been fully woken up, they need to lay on their stomach or slightly on their side flat to help facilitate the drainage of those secretions. Once they are fully alert, we can put them on their side or their back and with their head raised. Okay. Another thing we need to do with these patients after their TNA is to make sure they're not coughing, blowing their nose, doing any things that could cause excessive pressure, because that could cause hemorrhage. But how do we assess for hemorrhage? Why don't we discuss this in class and go into more detail there. Also, after the TNA removal, we're going to do PO liquids, PO Tylenol, and codeine. If they are not wanting to take anything orally, we may end up doing IV meds, but we try not to do those, right? We want to get that IV removed quickly. So we may end up doing suppositories. So a lot of the times for that first 24 hours, we'll do pain relief by suppository. We can do ice collars if the child will allow us, because that'll help with the inflammation, and fluids is important. But we want to make sure they're fully alert and we have no signs of hemorrhage. We're going to begin with water and ice chips. Make sure these don't have color to it. Reds, browns, citrus juices, things like that. Why would we want to make sure they're not those colors? Typically, TNA surgeries are outpatient unless the child has complications or are super young. So kids under 2 will watch closer, or let's say they have asthma or some other major complication. And then we will watch them to make sure that they're recovering okay. Otitis media, which is a middle ear infection. Most common illness in children 6 months to 2 years. Higher incidence in winter, seen more often in boys. It's linked to smoking in the house. Typically, they say there's less incidence with breastfed infants. However, I know tons of breastfeeding babies, and they have tons of ear infections. Some of it, I think, is related to how that tympanic membrane and the eustachian tube and all of that is formed. IgA, which we get through breast milk, it decreases the exposure of the tube. Otitis media is a black tube from edema, upper respiratory infections, rhinitis, hypertrophic, and adenoids. You also have dysfunctional eustachian tubes, which we know connects the middle ear to the nasopharynx. The tube normally opens to allow drainage from the middle ear to the nasopharynx, and it helps equalize external air pressure. When this is blocked, that pressure changes, and we end up having negative pressure. So that tube opens, it moves fluid into the middle ear and not out like it's supposed to. So therefore we have impaired drainage. And then we have retention of secretions in the middle ear. How do we tell? We look at that ear with an otoscope. Is there tons of drainage? Is that tympanic membrane discolored? Is it bulging or full? Red. Is there an earache? Is there fever? Do we see discharge? Is that kiddo crying and rubbing and pulling at the air? Do they have a decreased appetite? These could all be symptoms of an ear infection. What do? Well, typically we wait 3 days before we start antibiotics because sometimes just treating the symptoms and it'll help. So, heat or ice to the ear. We want kids to get their immunizations because that helps prevent infections. If it's really bad, we'll do an incision to the eardrum to alleviate the severe pain and drain that infection. We can also do tubes or tympanoplasty that helps equalize the pressure and help drain that fluid. Those tubes will fall out as that kiddo gets older. What are some complications of having otitis media? It's hearing loss. Hopefully it's temporary. Mastoiditis and meningitis. Why meningitis? Because your infection is so close to your CNS system, and if it's not treated well, it's easy access to get to your central nervous system. They can actually have tons of cholesterol buildup, and skin scales will form, grows, and invades the structures, including the bone. So that's a major complication, however, it's not common. Okay, so now we're going to talk about several different types of croup. Laryngeal bronchitis is one form of croup. It affects children that are under the age of 5. What is the cause of laryngeal tracheobronchitis? Typically it's viruses such as parainfluenza or RSV, which RSV proceeds an upper respiratory infection and then descends into your other structures. Another virus that can cause laryngeal tracheobronchitis would be influenza A or influenza B. So how does it work? How's the pathophys work? It has a very gradual onset of a low-grade fever, which then you also will have inflammation or edema of the mucosal lining of the larynx and trachea, which then leads to a narrowing of the airway. And if we have a narrowing of the airway, what do you think we're going to hear? So this is a nice little cartoon that gives you all the signs and symptoms and a little bit of like the etiology of laryngeal tracheal croup. So you can kind of look at it and it shows like the onset, like a slower onset, what kind of things we're going to hear or see with our assessment. So you can see the retractions, and you can see that you could have restlessness, vital words. They're going to have an increased respiratory rate. The age group, it typically occurs at night in the fall or winter. And they may have a little bit of a low-grade temperature, as you can see right here. we have a temperature of less than 102. This crowing sound or barking cough is very typical of croup. Okay, so we also have laryngeal tracheal bronchitis. And what are we going to do when we have laryngeal tracheal bronchitis? What kind of things are we going to assess for? So think back to health assessment class, you guys. What kind of things are we going to ask about? What kind of things are we maybe going to see in their history? So upper respiratory infections, right? That hoarseness, that stridor, or that barking. It could even be, instead of a crowing sound, like a seal-like cough. That dyspnea or tachypnea or tachypnea, depending on how you want to say it. That signs of increased respiratory distress and hypoxia. So what kind of things would be signs of respiratory distress and hypoxia? Retraction, stridor, increased workload of breathing. A very late sign we may see is cyanosis. So how do we help these kids with our treatment? Humidifier air, but it's going to be either cool mist or a steamy bathroom. I like to use the steamy bathroom. So go into that bathroom, make sure you don't have any fans going, and get that water going as hot as possible. And you know how you get that humidity and everything going on in there. That really helps open up the lungs. In hospitals, we'll use like a vaporizer or oxy hood or a tent to kind of simulate that stuff. We also want to make sure that the kid is sitting in an upright position or is being held in an upright position. And we're going to want to try to keep them calm, because crying increases that respiratory distress and hypoxia. If they're severely distressed with their respiratory system and severely sick, we are going to have them hold off on eating, because when we're eating and we're having trouble breathing, we could have increased risk of aspiration and a decreased work of breathing. We may even give some epinephrine through a nebulizer. So, severe NPO related to the aspiration, that increased respiratory rate. Signs and symptoms of impending airway obstructions is something we have to watch for too. So what would be those things we'd look for airway obstruction? Increased pulse, increased respiratory rate, retractions, flaring of those nares, increased restlessness, increased crying, increased accessory muscle use, so retractions or abdominal breathing, and that decrease in those saturation limits. What are some other besides epinephrine that we might give them? What about dexamethasone, like a steroid, may be possible. Another thing you may see is spasmodic croup or midnight croup. This is something that is sudden. It's proximal attacks of the laryngeal obstruction. Very sudden cough in the middle of the night. This kid is usually 1 to 3 years of age. It's very scary for the parents. They're not going to show any signs of inflammation or fever. They're going to wake up at night with the symptoms of that barking cough, the hoarseness, noisy respirations, restlessness, anxiousness. They're going to be frightened. And then you're going to have that increase in dyspnea. So what do we tell moms and dads to do in that instance? Go do cool air and a steamy bathroom or mist. So I do the steamy bathroom. So turn that shower on. And then as soon as that kid's resting and that bath seems to help calm down the breathing, take them right outside to the cold night air. Having both of those stimulations for the lungs allows that baby to calm, or that baby or child to calm down and breathe easier. What we will sometimes see is parents have this occur, and they get up and they do a few things, and then what do? They go head off to the doctor. And sure enough, by the time they get to the hospital, the symptoms subsides because they've been exposed to that cool air. This usually lasts a few hours, and the next morning they will be fine. Laryngitis. Laryngitis is a virus, more common in our school age and adolescent children. You have hoarseness is one of the main symptoms. I know we've all probably had laryngitis at one point. They sometimes will have that sore throat, nasal congestion, fever, headaches. We just treat those symptoms, and one thing to do is fluids and humidification. Rhinitis, so that's the due to atopic dermatitis or asthma, could be due to allergens. So we have a release of histamines and leukotrienes. Okay, so then we have tissue edema, mucus production. So what do? Nasal washes to loosen those secretions. So like your neti pots, things like that would be good. Bronchitis. This involves your trachea and your bronchi related to upper respiratory infections. Those kids will have dry hacking on non-productive coughs that tend to worsen at night and last 5 to 10 days. All we do is treat those symptoms. So what kind of things can we do to treat symptoms? Pneumonia. You guys have learned about pneumonia. So similar to the same things we're going to do for an adult, we're going to do for a kiddo. However, because their airway is so much more narrow, we need to maybe react a little bit faster because their airway will close off a lot faster. If they have chronic pneumonia, we need to look. Do they have like a reoccurrent chronic lung disease? Bronchitis or bronchiolitis or RSV. This can be very severe. It's an acute viral infection that affects children under 2 years of age mostly. However, some older kids can have it. It begins in late fall and peaks in the wintertime. It's very easily spread and very contagious. What is going on with RSV is that bronchial mucosa becomes very edematous, and then it fills up with mucus and exudates. These kids have because once again of that narrow airway, they are going to be at high risk for obstruction due to this edema. And so the air gets trapped, and they end up with hyperinflation, atelectasis, which is that air trapping in the distal area, and they get kind of emphysema-like. So, just in case I haven't mentioned it before, one rule of thumb is to kind of think about the size of a kid's airway is roughly the size of like their pinky finger or maybe their ring finger, so very tiny. Our book has a really good representation of a picture of the inside of an airway. So let's say the inside of a kid's airway is like 3 millimeters and the inside of adult airway is like 8 to 10 millimeters. And if you think about it, if that inflammation occurs with the same infection, they have less room for that swelling to occur, and it'll close off even faster. So kind of keep in mind when you're working with those pediatrics, the younger pediatrics, that airway is so tiny. And that is why things can get obstructed so easily, and we can have those issues. So what do we do for diagnosis? We look at the symptoms. It's going to begin with like an upper respiratory infection such as rhinorrhea or a low-grade fever, a little bit of a cough, or maybe some wheezing, ear or eye drainage. And then we're going to start seeing increased respiratory distress, like increase in coughing and wheezing. Then they're going to have that proximal cough that's intensifies. You're going to start seeing wheezing, crackles, those diminished breath sounds. Hopefully we'll get them treated before that. Severe symptoms or severe RSV is going to end up going into tachypnea or tachypnea, apnea, poor breath sounds, so coarse crackles, absent breath sounds, okay? And then the doctors are going to do an x-ray and they're going to see hyperaeration and consolidation in those lungs. Once again, we'll do ELISA, or the enzyme-linked immunosorbent assay, and this will be done by a nasal aspirate from the nasal secretions to confirm that it is RSV. What do we do for them? High humidity, lots of fluid, and rest. Hopefully most kids can be treated at home. However, some kids can get really sick and end up being hospitalized. We're going to do an oxygen hood tent with mist therapy, and that's going to relax everything and help those lungs open up. We're also going to do fluids. So this kid's going to more than likely be NPO for a little bit. So they're going to have IV fluids. We're going to do medications like ribavirin, which is an antiviral for really high-risk kids, to see if that helps. And then we're going to do other supportive treatment. So if there's a fever, Tylenol, things to calm them, cool environment. You may do those tepid baths. These kids are going to be isolated or be in groups of just RSV babies or children because we don't want to spread it to other sick kids in the hospital. It's very contagious. There are kids that we can give them a prophylactic shot. It's not really a vaccine, but it's kind of like our flu shot in a way. That for those really high-risk kids that are going to be easier to get the severe illness. So preemies, kids with chronic lung disease, immunosuppressed, kids like that their body isn't going to be able to fight off an infection like this as easily. Those kids will end up having the more complicated cases and could very well be the ones that are going to pass away from this virus. The prophylactic is called Synagist, or I never pronounce it right, Synagist, or the generic name is PLIVIZUMAB. PALIVIZUMAB. This is by an IM injection that is given once a month through the RSV season. Now, when is the RSV season? It varies from the first time we see our first case. Oh, I'm trying to think how many years ago in the NICU we had this. It was a really bad RSV season. I want to say our first case occurred like late September, and our last case of the year didn't stop until somewhere in July. So those kids were getting shots from the end of September all the way through July. Typically, like your flu season. These shots are extremely expensive as well, and they can be done by VNA, things like that. So it doesn't mean that they have to be in the hospital while getting the shots. Visiting nurses can come in, or they can go to their doctor's office. Epiglottitis is another form of croup. This is a very severe infection that can affect kids between the ages of 2 and 7 and requires immediate attention. I'm going to talk about this one in class a lot more. Why don't you guys take some of your own notes and then we'll go over it. This is just a good graphic on epiglottitis that I think would be great for you guys to be aware of. Once again, we're going to talk about management and prevention in class more. But one of the biggest things for prevention is that HIV vaccine. All right, so these medications hopefully you've covered in pharmacology. If not, I really want you guys to cover these on your own since we don't have tons of time in class. Okay? Okay, asthma. What do we know about asthma? Hopefully you guys know a little bit about asthma. This is a good little cartoon on asthma for you guys that kind of breaks down all those major signs and symptoms, triggers, and things like that. So, what are our characteristics of asthma? Chronic inflammatory disorder of airway, where you have recurrent episodes of wheezing, breathlessness, chest tightness, and cough. And typically we'll see this towards at night or early in the morning. Airway obstruction with hyperresponse to stimuli. Incidence, severity, mortality are increasing. I think some of that is due to poor access to medical care, where other diagnoses are weak. It is one of the most chronic diseases in adolescents. A huge reason why these kids are missing school, are going into the ER, and possible hospitalization. A lot of the kids have their first episodes usually during the night, and within 1 to 2 years they usually respond well to treatment. The symptoms that we're going to see are that cough, that wheezing, and shortness of breath. One thing that we'll do is pulmonary function tests using mechanical spirometer. However, asthma. So how do we classify asthma? We can classify it by 4 different levels. Mild intermittent is the least amount of symptoms, and it increases in frequency and intensity of the symptoms. Then you have mild persistent, a few extra symptoms, similar to the mild but have less symptoms. Moderate persistent, a lot more persistent, and then you're going to see it multiple times a week. Severe persistent you're going to see multiple times a week, maybe a couple times a day. So you kind of have this way to break it down. The etiology, we think there's a link with allergies in children. However, 20 to 40% of cases, there's no evidence of allergies. Could it be due to chronic lung remodeling or something like that? That's quite possible. In infants, it's often associated with viral infections. So asthma, what's the pathophysiology? It's that inflammation contributing to a heightened airway reactivity. So you have inflammation that increases your airway reactivity. Then you can have bronchospasms, which are caused by the inflammation and edema of the mucous membranes. And then you have an accumulation of tenacious secretions, a spasm of those smooth muscles of your bronchi, which then lead to an obstruction, okay? And then you have severe bronchial constriction as a result of these foreign stimuli. The smooth muscle around the airway causes a narrowing and a shortening of that airway, which then significantly increases the airway resistance to airflow. You may see a more pronounced symptoms during the expiration phase, since that's when the bronchi are contracted and shortened. Air becomes trapped in the lungs and those as the airways close. This trapping forces that child to breathe at higher and higher lung volumes. Asthmatics end up inspiring sufficient air but can't exhale it all. So one way to stimulate this is to breathe that and then you'll exhale back out. And then take another deep breath in and you'll exhale that. And you can asthma has not been well controlled and we need to call the doctor and maybe activate some sort of plan and make changes. If they are in the red zone, we need to stop and take emergency actions. It could be a medical alert and they have severe airway narrowing. So we need to give like a bronchodilator. So with these peak flow meters, they're establishing their personal best like a 2 to 3 week period once they're stable, and they're going to do it a couple times a day. And then they're going to compare that best with what is going on as we're controlling their asthma. So they're going to need to record it and have an action plan set up with their doctor. They're going to do it maybe once a week. After that first time when they're stable, they may do it a couple times a day, whatever their plan is doing, and then that can help us keep better control and treat their medications and their symptoms. So, an obvious sign of asthma would be absent breath sounds with those shortness of breath and increased respiratory rate. I'm hoping you've all heard of status asthmaticus. This is an emergency and that patient needs to go to the ER. They're in severe respiratory distress. They're having that chest tightening, that rapid increase of the shortness of breath, dry cough, wheezing. They typically will have this after like their respiratory illness or they've been exposed to an allergen or their exercise is inducing it. So what do we do to manage our asthma? Well, if it's due to allergies, we need to figure out what those causes are and then get allergy control. So we're going to do skin testing. A lot of asthmatics have allergies to dust mites. So if dust mites is my trigger, I need to get rid of carpet. I need to do lots of cleaning. I should probably get rid of my curtains. I can even put specialized cases over my mattress and my pillows to help those dust mites. You shouldn't smoke around kids with asthma. Certain bugs are an allergen, pets, chemicals, and allergies. There's a lot of things you can do to allergy-proof your home. Now, I know we can't always afford to get rid of carpet, so we are just going to have to clean it frequently. But dust mites and carpet, maybe they shouldn't be playing on the carpet, or we need to put barriers between them and those triggers. We can also do drug therapy, so we have long-term control and quick relief. The long-term control are those things that achieve and maintain the control of the inflammation, and then those quick relief types of things treat those symptoms during exacerbation. We have corticosteroids, which are anti-inflammatory. Cromolyn sodium, which is an NSAID. We have bioadrenergic agonists, so like your albuterol, and methylxanthines, like your Theodore or theophylline. So we know a lot of these kids are going to end up with metered dose inhalers, and they may have a spacer or a reservoir to prevent yeast infections. Remember, when we're using inhalers, we need to teach them to rinse their mouth between and use the nebulizer correctly. A lot of the times infants were using nebulizers because they can't use a metered dose inhaler. Oops, sorry, I didn't mean to write on that. Part of my word was cut off. Infants use nebulizers. Okay. Using an inhaler, we use it at the end of normal expiration, and then we release the medication from the inhaler. You breathe slowly and deeply for 3 to 5 seconds for better distribution. So you're going to hold your air for 5 to 10 seconds. Remove the inhaler and breathe out slowly. And then you need to wait like a minute between puffs. So we also teach self-care to asthmatics.
They need to use their peak flow meter. They need to avoid excess cold and smoke. Make sure they get their flu shots and their vaccines. They need to work on breathing exercises to strengthen their lungs. They need to avoid or minimize those triggers. So if there's allergens, and take their prescription medications as prescribed. In that acute care, we may have to do IV access for the medications and fluids. We're going to replace fluids slowly. If we replace fluids too fast, where's it going to go? You're going to have fluid overload and you're going to have pulmonary edema. And if you have pulmonary edema, what's that going to do with our airway? It's going to exacerbate that small airway obstruction. We're going to do nebulized albuterol and corticosteroids. We're also going to monitor their vital signs and the breath sounds pretty frequently. Small, frequent feedings. That way we're not working too hard. These kids are probably going to want to sit in a high Fowler's or more of an upright position. We're not going to want to over-oxygenate them either, because if we're not expelling out our CO2, and think of those COPD years, what's going on? Too much oxygen, and we're getting too much CO2 in our body, and it's just not going to help. We're going to decrease their anxiety, so we're going to have a calm environment, reassuring environment. We may not leave the kid alone, so make sure those parents are there with them. Give them distractions, but also make sure it's not too much noise or too much activity as well. Okay, so I don't have a lot of time to go through each of these different meds. So make sure you're looking at your farm notes, what a beta-adrenergic agonist is. Here's a nice little cartoon on bronchodilators. Epinephrine, adrenergic agonist. Once again, look at your notes. Xanthines, anticholinergics, leukotriene modified, anti-inflammatory drugs, your mast stabilizers, your anti-inflammatory corticosteroids. How do we give those steroids? And what are our contraindications? So like with prednisone and glucose, right? So what happens with prednisone and glucose? That would be something to be aware of if you're not on top of it. What happens with your GI system and psychologic system? Try to fill out all these blanks if you have questions in class. Here's a true and false. Answer it and I'll tell you in class. Okay. Cystic fibrosis is our next topic. So cystic fibrosis is an inherited autosomal recessive trait. It is an inherited gene from both parents with an overall incidence of 1 in 4. So if you look at my genome chart here on this slide, you can see both these parents are carriers, and one child is going to end up with the disease. One's going to be unaffected, and then you're going to have 2 other children that are carriers. What's going on with cystic fibrosis is you have an increased viscosity of the mucus gland secretions that then lead to obstruction. Mucus is produced by our body is usually thin. But in cystic fibrosis, this mucus is extremely thick. It has like this mucoprotein that's going on. And the CF, or the cystic fibrosis, affects all mucus-producing glands throughout our body. This mucus obstructs small passages in our pancreas and our bronchioles. In our pancreas, when those ducts get obstructed, we then end up having those essential pancreatic enzymes that don't reach our duodenum, and that affects our digestion and absorption of nutrients. So we end up with undigested fat, which creates bulky, frothy stools, or saturnaria. And then we have putrefied proteins that cause foul stools, azoturia. I'm not sure if I'm pronouncing that right. Azotorrhea. So you end up with stinky, slimy diapers. It also can affect those islets of Langerhans, and they're going to end up decreasing, which then could put them at high risk for diabetes later in life. They can also have liver fibrosis and biliary obstruction. And they're also going to have an elevation of their sweat electrolytes. So this is a nice little cartoon for you guys, helping you remember the treatments, what we're going to do, symptoms and such of cystic fibrosis. Okay, so you'll notice this has salty taste on the skin. So for instance, a mom and dad that may kiss their baby may taste a little bit more salt when they kiss the child from their just the natural ability of, you know, the sweat glands and different things. Their tears are going to be saltier than normal, things like that. So technically, if you would lick your child, you're really going to taste salt. Whereas if you lick yourself now and you don't have the disease, you're not going to taste salt. Oh. Okay, so cystic fibrosis has some complications. With your GI, they can end up with a prolapsed rectum related to those large bulky stools and malnutrition and malabsorption that's occurring. And they can end up with increased intra-abdominal pressure when they cough. They can also have intestinal obstruction due to impactions. Their pulmonary system has the biggest issues. Bronchi and bronchioles obstruct with those thick mucus, making it very hard for them to expectorate and make it very hard for them to breathe. A retained mucus is therefore a good medium for bacterial growth, so they're going to end up having lots of bacteria growing, which then leads to pseudomonas or pneumonias. It's dark, warm, moist medium. It could also be a good host for MRSA. These kids are also going to have poor O2 and CO2 exchange that create hypoxemia, hypercapnia, increased CO2, and acidotic type conditions. Diagnosis, we're going to look for that family history of the disease. We're also going to look for that absence of those pancreatic enzymes of lipase and amylase. They're going to have high electrolytes, particularly chloride, and we're going to see this in their sweat. So like I was saying earlier, that infant is going to taste salty, and that's due to that increased sodium. We're going to do a sweat chloride test. Normal sweat chloride test in people is 40 milliequivalents per liter, but those people with cystic fibrosis, they're going to have levels of 60 milliequivalents per liter or higher. We're also going to do a 72-hour stool sample to see how much fat is being expelled. And we're also going to look at their chest and see what's going on with their lungs. What do we do to manage cystic fibrosis? Most kids will develop respiratory symptoms by the age of 3. So we're going to want to prevent and minimize these pulmonary complications. So we're going to make sure they're having good nutrition for growth. So encourage physical activity and increasing their quality of life. We're going to prevent pulmonary infections. So we're going to try to increase aeration and decrease secretions. So how do we decrease secretions? We're going to do chest physiotherapy daily. They may do it 2 times a day. They may do it a lot more, especially when there's infections going on. We're going to do posterior drainage. So you can kind of see in that bottom picture that kiddo is kind of at a downward angle while they're doing the CPT. And that's going to help drain out that fluid while we're doing percussion. You have flutter mucus clearance devices, which you can see in this other picture with the little guy that looks like he has an inhaler. I know we've used this for COPD or patients as well. It's like a small plastic pipe with a ball in it, so when they blow in it, it vibrates, and that helps with the removal of mucus and increase the sputum expectoration. We may give these guys bronchial dilators as well. This is to help the ease of the expiration, and we'll do it before they do their CPT. Some kids will end up with a vest that they'll wear that they just turn on and it'll do the CPT variously. Some will actually have to do it by hand, like you see in that upper picture. The mom's doing it for her little one. This all will help with the expiration of that thick mucus. So managing complications, managing the complications, you're going to increase the amount and viscosity of respiratory and secretions and increase the chance of infection. And those infections are very difficult to clear. So how do we help it? We can do pomazine or an aerosol pulmazine, which is an aerosol medication that decreases the viscosity of mucus and improves PFTs. So helps with the expectoration and helps clear the airways. We're going to do physical exercise because that mobilizes secretions, and we want these kids to be normal, okay? We want them to run around. We want them to be active, because if they're not, that's going to decrease their self-esteem. So allowing them to be as normal as possible. These kids may end up with IV antibiotics when they're infected, so we may put central lines in them. Sometimes they'll use them at home. Sometimes they'll be using them in the hospital. Okay, we're going to be very careful with CO2 or with oxygen. It's going to be similar to they may have that chronic CO2 retention like a COPD. So chronic O2 is hard to wean. They're going to have that different respiratory drive like a COPD. Our biggest goal is to establish adequate breathing patterns with them and to get them through life. Well, their pancreas doesn't work, so we're having those enzymes that aren't being excreted from our pancreas to get into our duodenum to help with the digestion of fats and carbs, etc. So what do? We need to replace them. So we're going to be doing pancreolipase or pancrease. This is going to be given with meals and snacks, and the amount's going to vary. 1 to 5 capsules with meals, less with snacks. The amount is going to be adjusted to each child to maintain normal growth. And as we see the decrease in the number of stools to once or twice a day. We even do pancreolipase and pancrease in our infants as well. Unfortunately, it's not dissolvable. And it comes in a capsule form. So when you open the capsule out, you have all these little beads in there. So how do I give it to a 2-day-old infant or a 1-week-old infant? Well, literally, I take applesauce or something of that kind of texture and put it on my finger and then take up the amount of beads I need, and then I rub it on the top of their mouth, and then I feed them their bottle. Those beads will not go through a nipple of a bottle, so by putting it on the roof of their mouth with that applesauce, which I know they can't digest a lot of that stuff, but a little bit isn't going to hurt them because they need those enzymes. Then as they're sucking through their bottle, it's cleaning out that stuff from the top of their mouth. These kids are also going to do high protein, high calorie diets. It's going to be 150% of their normal recommendations. This is so that we can meet those needs for growth. Okay. They may need supplemental tube feedings as well. It's an incurable disease. However, we're having more and more success, especially of those people that are following along with their management and doing things well. They may end up with lung transplants later on. They may end up with other things, but it all determines, their pulmonary system determines their outcomes. Lung and pancreas transplants may occur as well. I've been hearing stories of kids or adults living into their 40s and 50s with cystic fibrosis. Back in the earlier days, they only lived to be in their 20s. Okay? So assessment. What am I going to do when I take care of a child with cystic fibrosis? I'm going to assess them. Look at that respiratory status. It's going to be similar to that of the asthmatics. We're going to check lung sounds, coughing, their clubbing. What's going to occur with clubbing? Why are we having clubbing? We're going to listen for decreased breath sounds, increase in tachypnea or tachypnea, increased efforts. Those lung sounds are super important because it's going to tell me what's going on in there. Okay. The clubbing of their fingers is going to tell me of thickening and flattening of the fingertips and that oxygenation status, right? Nutritional assessment. We're going to want to know the frequency and nature of their stools. Are they having abdominal distension? Are we having signs of failure to thrive? So that weight loss, wasting, pallor, fatigue. Are they having a decrease in their appetite? Food is a therapy for them. Are they dehydrated? Hopefully they're not, because if they're dehydrated, that means that mucus is going to be thicker, okay? And we're going to do family and child support. There could be grief counseling, especially if the family didn't know they had a family history of cystic fibrosis, and now we're dealing with a child with all these complications. It's a lifelong thing. Okay. We also want to do counseling about the good hand washing to decrease nosocomial infections, how to do CPT, how to give meds, what's the normal survival rate. You know, the book is saying in the 30s, but like I said, people that follow their treatment protocol have been living a lot longer. And we were able to do lung transplants and liver and pancreas transplants for these patients. You know, people can function normally now. And hopefully we're going to get these guys into further adulthood as our technology increases.